Hi everyone. Today I'm going to discuss the topic of wrist fractures. I'm Dr. Abdul Tawfiq from SNS College of Physiotherapy. Uh, I'll be presenting the wrist fractures and their management using design thinking approach. Shall we start? Yeah. What is wrist fracture? The wrist is a highly complex joint formed by a distal radius of ulna and carpal bones. Its mobility makes it essential for daily activities, but also makes it prone to injury. Wrist fracture usually occurs due to a fall on outstretched hand, commonly known as push injury. Early diagnosis and effective treatment are vital to restoring function and preventing the permanent disability. Maybe wrist fracture is simply a break in one or more of wrist bones. Distal radius is the most common fracture site, followed by the scaphoid. Fractures may be simple where bones remain aligned or complex with displacement or joint involvement. Causes. The leading cause is a trauma, especially force injury. Other causes include high impact sports, road traffic accident, and workplace injury in elderly individuals. Osteoporosis plays a key role in even minor faults can lead to fractures at the site of wrist while forcing the force injury or outstretched hand. It may cause impact on this or this type of injury maybe get infected as wrist fracture. What are the risk factors? Risk factors include osteoporosis in elderly patients, high energy sports in young adults, and may be get poor balanced or previous fracture, maybe anything else of elbow fractures, any biomechanically related fractures. Neuromuscular weakness also most common contributes while occurring of wrist fracture. These fractures either weaken the bone or increase fall of risk, making fractures uh, more likely. Clinical features. Patients usually present with pain, swelling, and difficulty moving the wrist. A classic sign in Cooley's fracture is the dinner fork deformity. Other features include bursting, tenderness, and reduced grip strength. In severe cases, nerve involvement can cause numbness or tingling in the hand. Types of wrist fracture. There are several types. Cooley's fracture, Smith fracture, Barton's fracture, Shepherd's fracture. Cooley's fracture, backward displacement of distal radius. Smith fracture, forward displacement of distal radius. And Barton's fracture, involvement in the rim of the distal radius. While getting the fracture occur, the rim of the distal radius also getting involved in it. It will cause bottom fracture. Shepherd's fracture or radial styloid fracture. Radial bone styloid process may be get fractured. Among the carpal bone, the scaphoid fracture is most common and cause serious complications in if we messed up. What are the diagnostic approach? Diagnostic approach with detailed history of injury mechanism. Clinical examination focus on deformity, tenderness, and movements limitation. X-ray are mainstay, while CT and MRI may be used for complex or hidden fracture, particularly scaphoid injuries. Here in the design thinking, we must emphasize with patient understanding their pain or fear of losing independence and concerns about the returning of work or sports. Anything else in the ideal activity? What is the problem statement? The challenges in the wrist fracture is to restore both bone structure and function while preventing long-term complications. Like malunion or arthritis. Each fracture types requires tailored management in future to retrieve management to retrieve their functional ability of the joint. So treatment options range from conservative to surgical. Stable fractures can be treated with casting and splinting, while displaced or unstable fracture are required surgical fixation. Rehabilitation is equally important to regain the strength and mobility. And coming to the non-surgical management, non-surgical management includes closed reduction and immobilization in the plastry, cast or splint for 4 to 6 weeks regularly. X-rays are taken to ensure the proper healing. This is the best suited for simple and stable fractures. Surgical management. Well, coming to the surgical management, open reduction and internal fixation with plates and screws. External fixation for complex fractures with soft tissue involvement may be used. Choices they depends on the fractures types, patient's age, and functional needs to the patient, which may get affected by the fractures. So post-operative post-op care focus on pain control, swelling reduction, and wound management. The wrist is kept elevated, and patients are encouraged to move their fingers and shoulders to prevent stiffness. Physiotherapy begins earlier and initial with modalities like ice, ultrasound, TENS for pain and swelling. The range of motion and gripping the strength exercise are introduced. Later resistance training and functional retraining restore the independence. These modalities are used while uh, check before an implant before using the stains. Something else, so rest of other modalities. It would be make it helpful for any other red flags. Coming to the complications. Complications and preventions can include malunion or non-union carpal tunnel syndrome, arthritis, stiffness, and reduced grip strength. The strategy is to prevent them before they get occur in the fracture site. Coming to preventions in elderly, fall preventions and balance training may be get helpful with bone health, and calcium of vitamin D may get supplement to use for their patients. In adults, use protective gear during sports and safe workplace practice. It may be get helpful. So, while concluding the topic, risk fractures are common but manageable with timely diagnosed, proper treatment, and structured rehabilitation. Using the design thinking approach, emphasize, define, ideate, and implement. We can ensure that patients are not recovered but return to functional independence. Thank you all. Hope you all understand this risk fracture. See you in the next topic. Bye.